Hey, welcome everybody. This is a special research presentation at Mailman Center. And our speaker is Jennifer Koto, who is a pediatric psychologist and assistant professor in the Department of Otolaryngology. Jen also has a secondary appointment in pediatrics and has been very involved with our pediatric psychology program for many years, beginning back after her graduation from University of Miami. I think, when was that, Jen? It was probably around 2007, something like that.
Yes.
Jen worked in my lab for basically running the place for a couple years, 2008 to 2010, maybe. But eventually her career brought her back to Miami, where she got her PhD in clinical psychology from Florida International University. Jen completed an internship with us at Mailman Center and a postdoc at the Children's Hearing Program in Department of Otolaryngology, and has been mentored by Yvette Sejas, another one of our premier faculty and the overall programs at the med school and with the Mailman Center. So today, Jen is going to talk about remote interdisciplinary team care in a pediatric cochlear implant population. Looking forward to your talk. Welcome, Jen.
Thank you. Thank you, Alan, for the wonderful introduction. So yes, I've been around for many years and have many great memories here in pediatrics with Alan and Lizzie and Jason and everyone else. So we'll go ahead and get started. So thank you for being here today. But before I dive into my research topic, I wanted to share a little bit about my research. So I know a lot of you from the pediatric side, but you may not really be familiar with what I do over here in otolaryngology. So my overarching interest is evaluating the effects of chronic illness on children's cognitive, social, and behavioral development. I really focus on two areas. So it's my mild traumatic brain injury, so just concussions, and then also in hearing loss. So I'll start off with my concussion work, and these are just a few highlights of what I've been doing lately. So in terms of concussion, I currently have a KL2 award here through the CTSI, and that project focuses on examining the efficacy of an objective measure to diagnose concussion. So it's actually these really cool goggles, and we're trying to see if we can diagnose concussion in kids using those goggles. And I'll actually be presenting on the norms of this at ARO in California this weekend. And my coordinator is also going to present on the Visit 1 results. So we're really excited about that. I'm also looking at how well the goggles do in predicting return to school or return to play versus standard neurocognitive screeners. So this is the study that's actually the renewal of my NIH loan repayment grant. I'm also interested in looking at risk factors for long-term recovery and academic outcomes. And we're actually waiting to hear back from a proposal that we submitted as a group in pediatrics with the CDC. So I also conduct research with pediatric hearing loss. So my mentor, Dr. Sejas, and I psychometrically validated a disease-specific quality of life measure for kids ages 2 to 21, so along the whole developmental spectrum. And then recently we also translated it to Spanish, and we're working on validating that. And that's actually the project for my initial NIH loan repayment grant. We also have validated a parenting stress measure, context-specific for parents of children with cochlear implants. Now, pre-COVID, we had a mental health screener that we implemented in clinic with adolescents, and we've published on the increased rates of anxiety and depression in that population. Post-COVID, we surveyed parents on their mental health and their parenting stress and strategies, and we've also published on that. And then another big piece for our team is Spanish-speaking patients and if they're assessed appropriately. So Dr. Sanchez, Dr. Sejas, and I created a survey to see what measures providers are using out there and how they're using them. And we've also created a study examining remote team-based care, which is what I'm going to talk about in a few minutes today. And then recently I bridged together the interest in both hearing loss and the vestibular system, and we submitted a grant to the American Cancer Society and to examine the psychological impact of NF2, which is a genetic disorder characterized by bilateral vestibular schwannomas. So enough about me. Let's get started talking about a project that was a team effort, no pun intended, but it was really just all of us sitting down one day thinking about the issues we were having during the pandemic and brainstorming on what we could do about it. And I thought this would be a great study to discuss today, given Mailman Audiology's recent merge with the Children's Hearing Program. So I thought it would be great and useful for the crowd to hear a little bit more about that. These are my disclosures. And what I hope you take away from this today is that you'll be able to describe a protocol for remote interdisciplinary team care in a pediatric CI population, identify the benefits of remote care on family burden and also mental health, and also just be able to discuss the feasibility and satisfaction of remote interdisciplinary team care. All right, so let's begin. What is interdisciplinary care, right? So the title of the presentation is Remote Interdisciplinary Team Care in a Pediatric CI Population. Well, what does that mean and what does that look like? So basically, it's all of these wonderful people coming together and synthesizing their disciplines into a coordinated and coherent whole. So in most audiology clinics, they state that they provide interdisciplinary care, but it's typically just what's necessary, right? So you need your surgeon and you need your audiologist, and sometimes they include speech. But yes, technically this is interdisciplinary care, but is there something missing from this? Can clinics do better? Spoiler alert, we can. So the Children's Hearing Program includes a clinical team. We have the ENTs, we have the audiologist, but we also have family support services. So our services include a listening and spoken language specialist, psychology, education, and also social work. So let's start off with audiology. So as part of our team, the audiologist provides diagnostic care as well as cochlear implant programming. So for those of you who don't know what that is, programming is when the audiologist checks that the internal piece or the electrodes are working, and they measure auditory responses from the nerve, from the auditory nerve, and they make sure that patients have appropriate access to different levels of sounds across the speech spectrum. So that's the audiologist role in our team. So typically the programming is done in person at the patient's clinic. However, especially in areas where there may not be a CI audiologist, patients may go to a clinic and then from there remote into an audiologist at a different facility. So this was kind of the standard when you would say remote programming before the pandemic. So at CHP, we also have individual consultations with the family support team as needed. So the listening and spoken language specialist may provide auditory or verbal therapy. We also have psychology, like myself and Dr. Sejas, who help families with mental health, adjustment to diagnosis, psychoeducational evaluations, and consults for behavior. Our educational specialists will assist families with educational placement, IEP development, and navigating the school system. And our social worker helps families with insurance and obtaining financial resources. All right, so this was all going great. We had a great model. It sounds amazing. And then the pandemic hit. So patients were worried about coming in, especially those that were multiply involved. Family support services, we really weren't using telehealth before. So we weren't seeing as many patients for ongoing therapy because patients weren't coming in, and we were really limiting who could come into the clinic. Also, all of the consultations that I mentioned before were happening individually, right? So families would meet with speech, they would meet with psychology, they would meet with educational specialists. And although our team is really great at communicating and sharing information with each other, the pandemic made it practically impossible. So what did we do? We had this dilemma in our hands, and where did we go from here? Well, we did what we always did over here. So we created a plan of action and a research study to go along with it. So we went off to secure fast funding because we needed a quick turnaround, and we were able to complete a research agreement with Cochlear Americas to facilitate this. And Cochlear Americas is one of the 3 cochlear implant companies. So what we did is we implemented a team-based virtual clinic. So we took what we typically did in clinic with our patients and turned that into telehealth. So there were 2 groups, one for children that are undergoing the CI process. So these kids do not have a cochlear implant yet. They're just going through the evaluation process. And then our other group is children who already had a cochlear implant. And we wanted to make sure that they already had, established access to sound. So we waited 6 months till after they had been implanted to enroll them in the study, because it's not standard of care to see those patients remotely. So we waited about 6 months. We also had 2 aims for the study. So the first aim was remote programming. So we wanted to look at the feasibility of remote programming. Of course, this was only for the children that had the CI post 6 months. And then We also created a team meeting that I'll get into detail a little bit later, but let's start off talking about the remote programming arm first. So remember how I mentioned that previously remote programming consisted of patients going to a clinic and then them remoting into a CI audiologist? Well, we wanted to really provide access and solve those issues with patients not being able to come into clinic. So we decided to go crazy and ship laptops and equipment to the patient's houses. So then at home, they could connect to our audiologist here in clinic. It was a fun experience and you'll hear about it later on. So what were our objectives? We wanted to know, does this work in kids? Can we do this at all? Do patients like this better? Are they satisfied? What are the financial implications? Do they save time from work, school? Are there other expenses that they won't incur if they are able to do remote programming? So we aim to enroll 30 kids. There's 3 different CI companies, as I mentioned, and we wanted to include all kids, but the companies had to agree to send us their programming cables. And one company decided not to participate. So those kids couldn't be in the study, but we did get patients from Cochlear and from Advanced Bionics. Like I mentioned, the kids had to have at least 6 months duration of CI use. They had to live in the state of Florida or had to be in the state of Florida during remote programming because of obvious licensing issues. And then they could speak either English or Spanish because our whole entire team is bilingual. So there was a whole list of to-dos with Dr. Sanchez primarily took the lead on. So the biggest issue we had was that it took a very long time for IT to be able to figure out how we could do this. We had to configure the laptop, so they only had access to Zoom and the programming software. We had to encrypt the computers. It takes a really long time to do this. We also had to make sure we received the cables from the company. We had to make the equipment user-friendly with handouts on how to connect, right? So we're sending these laptops and all these cables to the family's house. So we had to try to make it as easy as possible. So we made a lot of handouts. We also used stickers. So the programming cable would have a star and then the laptop would have a star where that was connected. So we tried to make it really easy for families. It was also pretty difficult to schedule patients. We had to be very strategic because we had to make sure that, we scheduled them with enough time for the laptop to get there. But then we also had to make sure that we had enough time for the laptop to get back. And our inventory was a little bit limited. So scheduling was quite a dance. Obviously, staff had to be trained on the study. Shipping supplies and labels had to be created. One big piece is that the patient programming files had to be loaded into the laptop before they got sent out. And then when they came back, we had to wipe the computer clean again so that none of the patient information would stay on that laptop. So as you can see, there was a lot to do and a lot to coordinate just to really get this off the ground and moving. So what are our audiological results from this remote programming? So we enrolled 30 patients and we were able to remotely program 27 of them. In terms of audiological metrics, everything was the same, which is exactly what we would want, right? So we want the same results in clinic and the same results at home. There was one pediatric outlier, but we later found out that the company that had their processor, AV, had a recall of their internal processor. And we think that that's the reason that there were differences in their impedances. Another big finding in terms of audiological results is that we saw that we were able to get the same thing done in 20 to 30 minute appointments versus slots that typically were booked for 90 to 120 minutes in clinic. So what typically took 90, 120 minutes, a very big clinic block, we were able to get it down to 20 to 30 minutes. So having similar results at home and in clinic, and then also having shorter appointment times, what are the clinical implications of this? Who can benefit? So basically, almost everybody can benefit from this, right? Now, we do want to make sure that it's patients that already have established hearing and appropriate responses in the booth, because we do like to get that first before we would say that we would remote program somebody at home. It's also good for patients who live far. There may not be a CI audiologist that's close by. Patients may have to travel just to see their CI audiologist. So this is definitely a good option for them. Also, children who are multiply involved, they're medically fragile, they're just high risk, and the parents would prefer not to have them to bring them into another hospital setting with others. Also, anybody who just is interested in convenience, right? I would love to, if given the option, just be able to log into a visit versus having to drive here, especially if I'm receiving the same quality care. It's also good for children who are hard to test. Sometimes kids just being in this medical environment, they don't do their best, they're a little agitated, and they might just benefit from visits within the comfort of their home. So this might help them be able to be more compliant with the testing if they're just able to be in their own environment at home and not here at an appointment with a lot of strangers. So of course, stats are important, right? When we're looking at results, and all of that is important. But I think that when you put it together, a study like this, there's so many lessons that we've learned that I think are really important for people to hear about if they're trying to implement something similar. Then they don't have to start at the beginning back and learn all the same lessons that we learned. So some things we learned is that the management of equipment is not easy. Many team members pitched in to drop off the laptops at FedEx centers. Helpful hint, you cannot fit a laptop sized box in our FedEx drop-offs here around campus. So we actually had to go to the FedEx centers to drop off the laptops. We were also fooled by Next Day Air. So apparently when you purchase Next Day Air, that does not mean that it will be on an airplane. There were several lost packages that ended up in West Palm Beach or somewhere else, and they were in a FedEx truck. They were not in an airplane. So Next Day Air does not always mean Next Day Air. So delays happen, right? Things happen in shipping, things happen at the FedEx center. Also, patients don't always send the laptop back as quickly as you would like them to. You would hope that they would send it out at least the following day, and that doesn't always happen. So you have to account for that time. Also, remote programming is convenient, right? And it provides more access, but it doesn't lead to better hearing outcomes. Like we said, we were seeing the same thing, whether you were in clinic or whether it was a remote visit. So it doesn't really improve your hearing, but it does make it more accessible and more convenient. Also, it can still be difficult to program kids. So kids who are just challenging to be able to program in the clinic, they might still be challenging to program at home. They're just sitting at home instead of sitting in clinic. Also, there were lots of issues with technology, both on the patient side and also the provider side. So for example, Chrissy one time was holding up a sign for a patient who was offline, so they couldn't hear. So she was trying to communicate with him with a piece of paper, and we didn't realize that Zoom mirrors it. So he was actually seeing the sentence backwards, and you'll see this in a little video that we put together. We also had a parent who logged into Zoom on their personal computer instead of the laptop that was shipped to them, where it had all of the things that they needed for programming. So there were definitely some technology issues on both sides that we kind of figured out along the way how to prevent them. So we have this amazing video that was created by Dr. Sanchez, and it's a compilation of some of the moments from the remote programming sessions that we recorded. You'll see that there's an adult in one of them, but we had a separate arm of the study where they were looking at remote programming in adults. But this presentation, we're only going to focus on kids. So I'll go ahead and play this. It's a few minutes.
How do you like doing this at your house when I'm on the other side of the computer?
Oh, because I don't know.
Do you think this is cool?
I love this computer.
Oh, and how are your ears? Are you hearing good?
Yep.
No.
Connected to the N7, now you're going to connect that to his processor, like the battery.
Oh, okay. Okay.
Yes.
Yes.
Perfect.
All
right, so
Hi. So I'm right on the money, man. I'm right on the money.
Right. Let's go.
You think it real hard.
This is the best you've ever done. I think you like being in your high chair at your house.
Yeah.
What do you think? Hi, Harley.
Dos más, Axel, dos más.
Hello, okay, one more time, you gotta do the sounds.
Update required.
Okay, does it give you an option to say not now, or does it just make you do the update?
I could say where the update is. Oh, it says contact the IT administrator to update. Or join us in from the Outlook. That's the closest. Usually it just says update.
Okay, so Irv, what I'm gonna have to do is send you a new laptop.
Okay.
And then as we get higher, you can start seeing the response happening. Oops. Did I disconnect from you? Oh, they disconnected from me. No, 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 no. He's being programmed right now. Oh, boy. The computer just restarted randomly. Oh no! In the middle of the program.
Yeah. Yeah, there was a Windows update, I guess, and it started doing it automatically. So I guess something to consider for the future.
Yep. I'm crying. No, how? Who? How are you? Yeah, how are you? I know it's silly for kids to drink coffee, but can I try it? No, yeah. Now I know why kids shouldn't have coffee.
You're so good.
Oh, that's why you're saying Alexa.
Yes. Oh, it sounds like Alexa. This is so much easier, man, than doing all this travel and everything. Oh my God, I'm a professional audiologist. You are.
All right, so as you can see, there were a lot of hiccups, but patients and parents really appreciated the remote programming. Things also got easier as we learned from all of these experiences that happened.
How do you like?
There we go. Okay, so what did we learn from that piece is that remote care is effective and it yields high satisfaction. It may not be for everyone, but it's an additional tool that we can use to just improve patient care and outcomes, satisfaction, and of course, access. All right, so now that we're done with remote programming, we're going to discuss AIM 2, which is the addition of the interdisciplinary team meetings. So there's been a lot of research with remote programming, and it's become very popular, especially after the pandemic. However, what's really unique about our study and our team was the team meeting. So we talked earlier how CHP typically has individual consultations with the family support services. But for this study, we wanted to do a remote team meeting with all of the providers. So all of the providers, the patient, the parents, sometimes even extended family members, whoever wanted to join could join, and they had access to their entire care team at once working together. So why is this big team necessary? Why do you need all of these people on a team meeting? Well, because hearing loss isn't just hearing loss, okay? So we know that hearing loss affects many areas of patients' lives, not just their auditory access or their speech. So for instance, hearing loss affects the entire family. Families with healthcare needs often incur additional costs, which impacts their finances. Also, time off from work can have financial implications. We also know that children with hearing loss are already at risk for lower educational achievement. So missing time from school can be harmful to them. Also, just coming into clinic itself can be stressful. 40 to 60% of children with hearing loss have another diagnosis, and it can be very taxing on both the parents and the patients to have to come into an unfamiliar place and be in close contact with unfamiliar people. Children with hearing loss also exhibit more behavior and attention problems, and as you saw from the video, it can be difficult or maybe embarrassing or stressful for parents to have to come in for the appointments. So hearing loss affects the entire family system, but specifically it could impact parenting stress. So we all know that stress is the physiological or psychological response to internal or external stressors. We also know that parenting stress can be general, such as topics related to discipline or safety, or they can be context specific. So in terms of cochlear implant population, it would be managing their child's cochlear implant or explaining a child's hearing loss to others. We have seen that parents of children with hearing loss report higher levels of stress, as we've done studies here within our clinic, and also developed that questionnaire related to parenting stress in parents of children with CI. So the literature also shows that parents are more stressed when their child has delayed language, as well as when they have poorer social and emotional development. Also, parents who are more stressed have kids with more behavior problems. And parenting stress is particularly important after the pandemic. So we did a study in our clinic that I mentioned earlier, and that we did find that the pandemic had increased mental health symptoms and parental distress in parents of children in our clinic, above and beyond parents who have children without any complex medical needs. So it's also well documented, both pre and post-pandemic, that parents and patients with hearing loss are at higher risk for mental health concerns, so particularly depression or anxiety. And we did a study during the pandemic looking at parents of children with hearing loss in our clinic, and we found that 55% had elevated anxiety, 60% had clinically significant depression, and 20% had elevated symptoms of PTSD. So this really demonstrates that need for mental health screening, for services, for access to these services, not only for our patients, but also for the parents. All right, so we got to the study here. So as we saw earlier for AIM-1, the remote programming seemed to work fine from a clinical perspective, but we also wanted to see if remote programming and the interdisciplinary team meetings affected all of these other patient outcomes that I've been talking about. So let's take a look at our sample. We had two groups, as I mentioned. The remote programming group had 27 families. Most of them were mothers with a mean age of 38 years. About half were Hispanic. Most were married or living with their partner and had completed a bachelor's degree or higher. Most completed the survey in English, and the kids had a mean age of 6. The ones in the CI eval arm, there was 10 families. All of them were mothers with a mean age of 33 years. About half were Hispanic and completed a bachelor's degree or higher. Most of them were married or living with their partner. 80% completed the survey in English, and the kids had a mean age of 2.2, which is appropriate because typically when we're getting kids implanted, we want to make sure that we do that earlier than later. So in addition to the audiological measures that I spoke about earlier, we looked at the other sides of hearing loss, right, that can affect our patients. So anxiety, depression, parenting stress. We also wanted to see if parents were satisfied. Did they like this treatment setting? Did they like this service delivery model? We also wanted to look at family burden related to the appointments. So attendance, expenses, time off from work or school. So for anxiety, we used a GAD-7, which I'm sure many of you are familiar with, and it measures anxiety in a 2-week period. For depression, we used a PHQ-8, which measures depression on a 4-point Likert scale, and it's also in the previous 2 weeks. We used a parenting stress index. In particular, we looked at the parental distress subscale. So this really captures parents' level of distress related to conflicts with a partner or social support, and stress resulting from life restrictions due to parenting. Now, for treatment satisfaction, we asked for both groups, right? We wanted to see how were they satisfied during the in-person visits at first, and then how were you satisfied after the remote visit? So we asked questions such as, was it easy for you to attend your in-person clinic appointment? Was it easy to get to your appointment on time? How satisfied were you with that visit? How do you rate the overall quality of care that you received during the visit? Then we also looked at, compared to an in-person visit, how much time did your provider spend with you? Was it more? Was it the same? Was it less? Also, what did they think? The amount of time that they spent with their provider, was it too much? Was it just right? Was it too little? And then we wanted to know, how would you want your next visit? Would you want it to be in person? Would you want it to be remote? Does it not matter? Either one works for you. So we really wanted to see what parents thought of the in-person versus remote visits. We also wanted to look at family burden, and we did this also for both in-person and remote. So we wanted to know, during your last in-person visit, what expenses did you have? Did you have to pay for parking, gas, food, hotel, childcare, all of that? We also wanted to know, how much time did you have to spend away from home or from work? And what type of time off did you take? Was it unpaid time off? Was it paid time off? Also, did your child have to take time off of school to attend this appointment? All right, so here we are at the results section. So what did we find? So we saw that parents were satisfied. They were satisfied or very satisfied with both. Whether it was in person or remote care, they were satisfied with both methods. They also thought the quality of care they received was excellent, both in person and remote. And this is good, right? We want patients to be satisfied no matter how they see us. If they see us in person or if they see us remotely, we want them to be satisfied, and we want them to think that their quality of care was good. The only difference we did see was in the parent preference for visit type. So after the remote visit, 74% of parents preferred for their next visit to be remote, whereas 22% were indifferent and 3.7% preferred another in-person appointment. Parents also thought, of course, that in remote programming, as we could expect, they thought it was very easy for them to attend. So 100% strongly agreed that it was easy for them to get to their appointment, versus in person, about 46% disagreed that it was easy for them to attend. Getting to appointment on time, also, as you would expect, the remote visit, 100% agreed that they could get to their appointment on time, versus 46% disagreed that they can get there on time. And their time spent with the provider, it was nice to see that even though the appointment was cut shorter to 20 to 30 minutes versus that 90 to 120, they thought that they had just the right time with their provider, both in person and remote. So mental health, we really didn't see too many differences. So we did see decreased levels of parenting distress during their remote visit compared to their in-person visit. In terms of mental health, there really were no changes observed by the service delivery model. Family burden. So parents reported many expenses for their in-person visit. So the biggest one was gas, then there was mileage, parking, food, and also childcare. For the remote visit, parents did not report any expenses. So this was really nice to see that there was also a big difference in how much money families had to spend to even get to the appointment. We also found that remote care decreased the time away from school and work. So during the in-person visit, 31% reported missing over 4 hours or more of work. While after the remote visit, 93% reported not having to miss any work at all or less than 2 hours for that remote visit. And this was similar for time off from school, with most children not missing any time off, any time from school after the remote care. So this is really significant because we really want kids to stay in school, especially kids with hearing loss. We don't want them missing a lot of that learning time. So looking into those that reported taking time off, 46% of parents did not get paid during their time off, and 44% of them had to coordinate with someone else for other caretaking responsibilities that they might have, and that was for the in-person appointment. In the remote visit, only one parent had unpaid time off that they had to use, and only 15% of parents had to coordinate with someone else for other responsibilities. Now to our team meeting. So all families reported being extremely satisfied with that team meeting. They thought that it was extremely important for child's providers to work together and be in one meeting together at one time. They also thought that all providers were on the same page regarding their child. When we asked which of your remote visits with the interdisciplinary team was most beneficial, 56% said their listening and spoken language specialist, 22% said their psychologist, and 19% said their educational specialist. So we also asked, how did parents want to meet in the future? What would you want to do for your next visit? So they said they would prefer to meet every 6 months as a team remotely. Also, most parents stated that they wanted additional visits, telehealth visits, before that team meeting with their LSL, with their educational specialist, and also with their psychologist. So what are some clinical implications? So the integration of remote programming appointments may serve as an excellent service delivery model, and this can help reduce family burden and improve parent well-being. So we really want to continue advocating for insurance reimbursement so that all families can have access to these services and to a team like this. So remote programming is also time-efficient alternative to ensure appropriate device function. So as we saw from the data in this study, we can improve school and work attendance and decrease financial burden in our families. Also, remote services have the potential to optimize efficient scheduling. So first, we saw already right off the bat that the programming appointment can be done in a 30-minute slot versus an 120-minute slot. So that definitely makes for more availability and really getting through that wait list that we have. Also, in-person appointments can be reserved for patients who actually need it. So patients can be seen at home and don't have to fill up the clinic day. We can really save those spots for patients that need to come in and need to be seen in person. Also, it can help with patients who are often rescheduled after they can't complete their testing during their appointment. So there may be some kids that just aren't compliant that day, and we spend a while trying to get what we need from them, and we're not able to. So then we have to make another slot and have the parents and the patients come in again and take up another slot to try to do their testing again. So they may be more compliant or comfortable at home, and then we won't need to keep rescheduling them and having the parents come in, or really taking up those clinic slots for maybe patients that need to be seen in person. So some final thoughts: general remote care access. So just a general remote care across the entire scope of pediatric hearing loss is rapidly emerging. There's other centers that are trying to do this, that they're trying to get remote access to their patients. Remote cochlear implant programming is gaining traction, and it really fits into the future of practice. We really see that patients enjoy it and they prefer it. So we really do think that this is more of the future of healthcare. Also, implementation of a remote team-based interdisciplinary practice is feasible. We can do this. We were able to do it. We were able to get all the team members on there. Also, families are highly satisfied with it. They like it. Our sample preferred remote care over in-person visits. So it really does improve satisfaction in care. And then also remote care ameliorates barriers to clinic appointments with a reduction in expenses, time away from school, and does have the potential to reduce parent distress.